Well, I'd like to offer a warm welcome to today's special guest, Craig Thompson, Chief Executive Officer at Golden Valley Memorial Healthcare. And Craig, this is your first time on our podcast, and we're so excited to have you here today to talk about what's happening in the corner of your world, which I'm assuming is going to mirror a lot of what we're facing in rural America in general. But I'm excited to talk about what's happening at Golden Valley Memorial Healthcare. If you could just open it up with a little bit about yourself, how long have you been there? What brought you to the organization? And ultimately, for such a time as this, why in the world did you choose this field?
Well, thanks, JJ. I appreciate you having me on today. And I do also appreciate you mentioned this is my first time on the podcast, which means there's an opportunity for a second time.
Oh, there is.
We'll see if that holds
Absolutely.
true after we're done.
It will, I promise.
So, I'm the chief executive officer of Golden Valley Memorial Healthcare. We are a rural provider located halfway between Kansas City, Missouri, and Springfield, Missouri, where
Okay.
our main campus is located in Clinton, Missouri. And if you're familiar with Missouri geography, Missouri is a little bit unique, and we've got really two major metropolitan areas, St. Louis and Kansas City, and then kind of a third quasi metropolitan area in Springfield. So we sit between two metropolitan areas, but we cover a very large geographic footprint,
Mhm.
partly because there are a couple very large lakes in the way. Truman Lake and Lake of the Ozarks are all within our
Oh, yeah,
service area.
absolutely.
And that in itself creates some challenges, as many
Yeah,
of your listeners understand who work in either mountainous terrain or areas with lakes. Sometimes you have to go north to go south. And
sure.
so that does create some inherent access issues.
Oh, yeah.
But I've been with the organization now for 30 years. It'll be 30 years in June, actually. So
Wow.
approaching my 30th year. I know as you see me on the screen, you couldn't imagine I could be
I
anywhere for
did
30
you
years.
start at 10 years old or what?
Well,
You know?
I feel like it at times. Uh, but the reality is, I'm a clinician by background. I'm a physical therapist,
Oh,
and
nice.
I started with the hospital right out of PT school, and then have had opportunities to do a few different things along the way. I was the chief operating officer for about 10 years, and I've been in my role now as chief executive officer for almost 10 years as well.
Well, that's incredible. And obviously weathered a lot of storms during that period,
Yep.
economic shakeups, COVID, all of that, and still doing remarkably well. In terms of the geography of your
Mhm.
locations, can you give us a sense in terms of your hospital size overall, as
Yep.
well as what is your catchment of patients? What does that number look like?
Yep. So our total catchment area is about 80 miles. If you
Oh,
could kind of draw an oddly shaped circle around us, people come from as far as 80 miles away.
that's incredible.
We consist of our hospital, and then we have a number of rural health clinics and multi-specialty clinics,
Sure.
as well as radiation oncology, a number of freestanding therapy services, really extensive cancer services. We employ right around 1,000 people total, and we employ right at 100 or so providers, and then have a number of others
Wow.
that we contract with along the way.
So, major operation. And we're going to talk a little bit about some of the impact that state and federal legislation has had and will have into the future on your hospital, hospitals like yours in rural country. But before we do that, it's always good to kind of connect our listener with our guest. And we always like to do a fun little fact, maybe an interesting fact about yourself that would just be like, wow, that's neat to know to kind of humanize you to our audience.
Yeah, so I was thinking about this question, and I want to share a story to kind of maybe provide a little bit of insight. So, I'm a pilot and a
Oh,
private
wow.
pilot, and although I haven't flown now for almost 12 years, but technically, once you're a pilot, you're always a
Oh, yeah.
pilot,
You're always a pilot. Yeah.
and as long as I could pass the medical exam, I could jump in a plane tomorrow and fly. Now, I wouldn't recommend flying with me. Uh, I I tell my wife all the
I'll
time.
skip the
Yeah,
first flight.
I agree because there may not be a second. I share
Yeah,
with my wife
exactly.
all the time. I would have no trouble jumping in an airplane and taking off.
Yeah.
The trouble would be I don't think I could land, but she reminds me it'll always land.
It'll land.
Yeah,
It's just in what manner will it land?
she's right. And what had happened was a few years ago, I decided to go for a flight one day, and it was a safe day to fly, but it was a little bit windy, so I was going to have to lean into the wind and crab it in as I landed on the runway, and it felt very uncomfortable. And I
Hmm.
decided, you know what? why am I doing this? Because prior to that, it had probably been almost 2 months before I'd flown that time. And I realized I just wasn't doing it enough to stay proficient.
Yeah.
And that's kind of the way I feel every day all of a sudden.
Yeah,
There is
it
so
is.
much change and so
There
much
is.
uncertainty coming at us. I'm
There
worried
is.
that I'm not staying proficient.
Yeah.
And that's why I appreciate your podcast, the information that you share, your advocacy, and that of others as well, because we have to do everything we can right now to try to stay proficient, and making sure we're informed of what the issues are is one of the ways we can do so.
Fully agree with you. Great perspective, Craig. Certainly, there's not a day that goes by that the Becker's articles don't pop on my email, and I'm going, wow, that's something new and interesting that we're going to have to tackle. And it is an industry that is so dynamic.
Mm-hmm.
And I know every year that I am serving in this role, I say it every year, that it's more and more dynamic, but it is incredibly challenging right now for us. And we're going to talk about that in just a minute. And today, for our listeners, we're talking about maintaining local access to care in rural, remote areas and how rural hospitals must think outside the traditional box to solve those problems facing our health systems today. Craig is here to provide insight and experience as a chief executive officer of 10 years and 20 years prior to that in leadership roles at a rural independent healthcare system. We'll talk about local access to care, federal funding, and of course, what all this has to do with rural health. So let's jump right into it, Craig. So, you've been a healthcare leader, it sounds like, for decades, most notably the last decade as the chief executive officer. What would you say are your primary concerns about local access of care for your community? And I want to do that in a two-part series. And in what ways is your hospital system tackling these challenges today?
Yeah, I think my biggest concern as it relates to access is understanding what access is, because I think we many of us likely provide primary care services, and primary care services for us is really the heart and soul of who we are. It's the entry into everything that we do, and the relationships that our patients have with their primary care providers. Those are sacred.
Hmm.
It's in a lot of cases, and for many of us, outside of our spouse and our children, our loved ones, it's our most trusted relationships. But even that relationship right now, to some extent, is under assault. We
It
can all
is.
pick up our cell phone and we can have a primary care visit. I would argue it's not the same quality. I would argue that it doesn't provide the same continuity,
Hmm.
but someone's trying to chip away at that. And so when we think about all the things we do, nobody wants to chip away at the stuff like emergency services or birthing services that have zero margin and have high risk. Nobody wants any of that. But
Right.
we have all kinds of disruptors in the world who are trying to chip away at the stuff that we that are vital to our ability to provide
That's
care to
right.
our
That's
communities.
right.
And in rural communities, access is not just their lack of public transportation, but access is also driven by the lack of a payer source.
Hmm.
Access is sometimes driven by the fact that even there, if there is a payer source, there are high deductibles that get in the
Hmm.
way of a patient's desire to receive the care that they really need. And then beyond that, there's technology components that really impact access. So we're doing a number of things to address that. We know that at times our patients simply can't or won't travel for the care they need.
Right.
And we do everything we can to provide as many services as possible to our communities so that they don't have to travel. Um, just recently, and really we unveiled this to our community last month, we were fortunate to have received a grant and then had some private donations to help to purchase a 36-foot long RV. And within that
Nice.
RV, it's equipped with a 3D mammography machine.
That is incredible.
So we have several clinics that offer mammography services, but there are several communities around us that don't have access to those services. So we now plan to take that care to those
That's
individuals.
incredible.
We are so excited about that service,
Yeah.
really to expand that reach. With any cancer, early detection is key for the best
Right.
outcome.
Right.
Mammography is an easy screening
Sure
opportunity,
it
but
is.
if you can't access it, you don't have that same opportunity.
It's incredible work that you and your team are doing, and what a visionary. It's so costly. And if you look at it from a CFO perspective, and so far CFO friends are listening, I'll apologize in advance. Oftentimes they tackle us with, well, there's no ROI here.
Mhm.
This is it. But you and I know as leaders in the organization, sometimes it's not about the ROI. It's
Mhm.
about the quality of healthcare that we can provide to our community. Healthier communities, readmission rates lower. They're not coming into the ER sicker. And so it sounds like you've got a great handle of it in your corner of the world. So congratulations to the work that you're doing. Now, let's shift a little bit because each of the guests that we have on here, the staff give me a bio.
Mhm.
And I sent an email back and said, this guy should be interviewing me, not the other way around. You have done a lot in advocacy. And I want to get into your specific work with the Ways and Means, some testimony that you provided and some work you did. But before that, let's just talk about advocacy in general, right?
Yep.
There seems to be a lack of it. There seems to be a lack of telling our story.
Mhm.
There's this assumption that we're nothing more than waste, fraud, and abuse. There is this assumption that we are, deep pockets, and it's just the opposite of that. We are one, catastrophic lawsuit away from closure. We're from one average commercial rate departure from Medicaid with a one big beautiful bill from closure. All
Mhm.
of those challenges are present, but one of the areas that I think we can exercise our voice is in advocacy. And so I want to ask you this question. It's a general question first before we dive into it, but how can advocating for rural health care at both the state in the state that you're in and federal level um, help us as an industry maintain local access to care? Let's talk about it, broadly at first. Then I want to get into the weeds a little bit.
Yep. Yeah. And you've mentioned it already. The reality is, we have to tell our story because if we don't, someone's going to tell a story
That's right.
for us.
That's right.
And I spent a lot of time in Jefferson City, Missouri, which is the state capital. And right now, our legislature's in session. And so during session, I try to make it to Jefferson City at least one time a week. And then
That's
throughout the
great.
year, I try to make it to Washington, D.C. to meet with our Missouri delegation there at least four times a year.
That's great.
And sometimes I have very specific advocacy topics. Sometimes it really is just to show up and make sure that there's a face with a name. But to your point, telling our story is vital
Mm-hmm.
because there are all kinds of industries and all kinds of entities that are trying to undercut what we do and
Yes.
get a piece of what we do. But without us taking the time to tell our story, there's going to be a story that legislators
There sure
listen to
is.
because that's
There
what they're
sure is.
hearing. And I
Yeah.
think it's uncomfortable at times. If you've never done it, it's uncomfortable to
Very.
walk into a lawmaker's office and meet with their staff or to meet with them. Um, but reality is, and if you've ever had this experience, you understand it, you actually get more face time and attention than a professional lobbyist. They see professional lobbyists all
Ever.
day long.
All day long.
They're more willing to listen to someone who does it, sees it, feels it, and hears it than they
Yeah.
are those professional lobbyists.
Absolutely agree. And to our listeners today, you've heard it directly from someone doing that work. Craig Thompson with us, Chief Executive Officer of Golden Valley Memorial Healthcare, who's leading the discussion in Washington and his state regarding the importance of local access to healthcare. And there's too many challenges facing us today, but you heard it directly from him. Let your voice be heard. Make your contact with your state and federal authorities. Take a tour. Make it a point to go visit, and then invite them back onto your campus to see what's happening firsthand. The constituents in their community who need to lift their voice and tell their congressional leaders and their state legislators why it's important to keep local hospitals. Craig, some of the work that you've done has been on the Committee of Ways and Means, which is a very powerful committee. And you've had the opportunity to address specific topic as it relates to rural hospital reimbursement, or at times what you and I feel is a lack thereof.
Mhm.
So why don't you talk to us a little bit about that work that you've been engaged in?
Yeah, specifically, I've met with the Ways and Means Committee staff on several occasions on the topic of residency. We are in the process of standing up a residency program,
Good for you.
which will be a family practice residency program. And we were fortunate to have received a grant from HRSA to help us stand up this program. If anyone's ever set up a residency program, it's complicated. All the work around graduate medical education has to be done right. We all want highly trained physicians. There are specific things you have to do along the way to become accredited as a residency program. So we were fortunate to receive this 3-year grant from HRSA
Congratulations.
that
That's
really
great.
really holds our hands and helps us stand this program up.
Mm-hmm.
So that piece we have covered. But what we recognized along the way, and other rural hospitals who are also trying to stand up these residency programs, there are about 3 others in the state of Missouri right now who are on the same timeline as us and trying to stand up a residency program. What we recognized is that for Medicare dependent hospitals and sole community hospitals like us, we receive about $75,000 less in reimbursement per resident per year,
Mm-hmm.
as opposed to and compared to our urban and suburban counterparts who
Sure.
offer residency training. And there are really 2 different components of reimbursement for residents. One's through the GME process, and one's through the IME process.
Yep.
Well, for whatever reason, sole community and Medicare dependent hospitals do not get IME reimbursement, which means we receive about $75,000 less per resident per year. Now, if you think about that, the more residents you try to put through your program, the more it costs you to do
Yes, it
so.
does. Yeah.
And there's really a financial disincentive. JJ, you understand, and other rural hospitals understand. We can provide a great training ground for family medicine physicians, because our family practice physicians, and I suspect yours are the same. They're not just family practice physicians; they're
No.
cardiologists, they're
Yes, they are.
pulmonologists, they're urologists. They
They're
do it
everything.
all.
They do it all.
It's a great learning environment. What we also know is physicians are more likely to practice in areas in which they train. So if we can train more physicians in rural areas of the country, they're more likely to practice in those rural areas because they recognize, like you and I do, the beauty and joy of living in rural parts of the country.
Mm-hmm. Absolutely. So, how would you characterize your success so far in trying to lobby for this?
Yeah, yeah, and I need to give credit where credit's due. There's a lot of people who are really
Sure.
advocating for this same fix. And Jason Shinefeld, who's the CEO of Phelps Regional Hospital in Rolla, Missouri, has also been a strong advocate around this same topic, and I appreciate his
Good.
engagement and involvement. We are very fortunate right now that Chairman Jason Smith, is the chair of the Ways and Means Committee. He is from Missouri.
Oh, that's great.
And he does recognize the importance of rural health care. And so having that support has been beneficial. And we believe we are making significant progress. Matter of fact, the last time I met with Ways and Means staff, they promised some legislative text that would fix this problem and would start to provide not only this equalization and reimbursement, but in addition to that, for these rural residency programs, also some startup costs to help offset that startup component. So it's not in hand just yet, but they've promised we're going to have that in a relatively short period of time.
Well, congratulations. And it's proof that advocacy does have a reward. And
Sure. Yep.
Obviously, to our listeners today, you have unique issues just like issues that are facing Craig and his hospital. Lift your voice, reach out to your congressional leaders. I think that's our lesson for today. All right, let's shift gears a little bit because, as you know, the H.R. 1, also known as the One Big Beautiful Bill, comes down. We're told by 2032, $1 trillion cut, majority of that Medicaid program. I'm not sure if Missouri is a Medicaid expansion state. Michigan was. What that does is it removes that average commercial rate that you were getting, that delta between what you were getting paid for Medicaid and then with the expansion, the ability to pick up that uplift. Hospitals in our region in the state of Michigan, for example, mine, $6 million loss every year annually in that reimbursement. And when we're on a shoestring budget and a very razor-thin margin, $6 million is you're out of business. You can't do that. It just doesn't work. And so there's been a lot of conversation, though, from congressional leaders that it's all going to be fixed with the Rural Health Transformation Fund, RHTP. So they took away $1 trillion. They give us back $50 billion of $1 trillion, and of that, it's divided by the states. And I'm not sure where Missouri, how you fared in terms of the number, but in Michigan we're 173 million. You divide that by all the hospitals. You divide by who's eligible. How do you define rural? And then all of a sudden you're looking at mere pennies. But then each state designed their program based on whoever the governor of the state appointed to be the lead. And I would like to learn a little bit more about how it happened in Missouri, what you feel about the outcome, because I can tell you in Michigan it's a hot mess. None of these funds are going to be used to help supplant any of the losses that we're going to sustain either from the tax credit rollback, under the rollout, or is it going to help us at all in the reduction through H.R. 1? So give us an overview of what your state went through, if you would, and how do you see these dollars being allocated as a benefit to your organization?
Yeah, so Missouri is an expansion state. We actually expanded Medicaid through a constitutional amendment from
Oh,
the
wow.
vote of the people, which actually complicates a few things right now. And if we have time, I can touch on that
Please
later.
do. Yeah.
Um, so, so Missouri actually did very well in terms of their application to CMS for Rural Health Transformation Program funding. Missouri is the ninth highest award in the country,
Mm,
even though in terms of rurality we're about 21st in terms of actual rurality across the country. We received 216 million here in year one, and the challenge, though, is there are about 2.5 million rural residents in the state of Missouri. And if you do the rough math, 2.5 million residents at 216 million total, that's about $83 a head.
yeah.
So the opportunity to be transformational,
Mm,
I think, is going to be a little bit of a stretch, and
agree.
it's going to be a challenge. And when HR 1 was being deliberated, and it was actually Senator Josh Hawley, who's a
Hmm.
Missouri senator, who
I
helped
saw
to
it.
champion this rural hospital stabilization fund.
Correct.
So if you remember, it was not
Oh,
a
oh, I
rural
do remember. Yeah.
transformation program.
Yeah.
It was a
True.
rural hospital
That's right.
stabilization,
That's right.
which is very different, the two.
Sure is.
And um, what I am beginning to worry about and recognize, among other things, is because this has moved from a stabilization program to a transformation program, the only real way to achieve transformation is to take the training wheels off and
Hmm.
let us try to do some things that are transformational.
Agreed.
Um, but what I'm beginning to realize is um, no matter what the state's planning and no matter which state it is, um, there aren't opportunities to really color outside the lines,
No.
which is going to make it harder to be transformational. As a matter
Agreed.
of fact, I learned this week for all states, even when those states are putting out a press release about their program, they have to send that press release to CMS.
Yes, they do.
CMS has to edit and approve the
Yes, they
press
do.
release before they can send it out to their constituents.
That is very
Uh,
true.
that just speaks of bureaucracy,
Sure does.
and we know every single day and have to live in a world every single day where bureaucracy limits the ability to be transformational and creative.
Powerful and absolutely on point. And that's exactly what our states across this union are facing today as whoever the fiduciary is of that respective state builds, their boilerplate templates
Mhm.
and the processes that they go through. Some are going to be heavy burden and a heavy lift for rural hospitals to fill out applications, go onto
Mhm.
state portals, apply for program in nature. Programs in nature create legacy costs. How do we continue legacy cost? A lot of questions still have not been answered, but certainly I would venture to say to take out the word transformational because it's far from that. I do want to go back just a little bit. You raised an interesting fact. When the people of the state of Missouri enacted this expansion, I don't know if any other state that did it by virtue of the people. It's usually the legislative body that did it. So, does it have implications for setting within statute this requirement to provide that uplift? How does that work?
It does. And so what now becomes complicated with HR 1, and I don't want to get into all the specifics around HR 1, but what we do know is there are differing levels of reimbursement
There
and
is.
differing levels of support based upon the Medicaid population and the expansion population.
Correct.
And because Missouri expanded Medicaid through a constitutional amendment, Missouri can't separate the two.
Wow.
So any reductions in any kind of services to the
Wow.
expansion
Comes
population
from the state.
has
They have to pick it
yes,
up. Oh my
yes.
God.
So it has really created a lot of
Wow.
statewide discussions around how do we manage this cost. For our traditional Medicaid population, it would have been X. For the expansion population, it would have been Y. But we can't separate the two and have to provide the same benefit to the entire Medicaid population, expansion or not.
Craig, you better close in prayer on that one because I'm telling you right now, you're blessed beyond measure because it's statutorily required now. And in states like Michigan, that delta does not have to be made up by the state legislature. They just drop it. So you're in a unique position to force the hand of government to actually cover those costs, which means you're going to have less loss than most hospitals in our nation. It's a great position to be in.
It is. Now the challenge with that is,
Where will they
and
take the
one
money from?
that's it. Yep,
Yeah,
exactly. That's
yeah,
it.
yeah.
Because Missouri has been one of the states that's been, I think, unique in our ability to leverage the provider tax specifically. And without that process in place at this
Hmm.
point, um, they're going to have to look at general revenue to support the Medicaid program. So, are we going to
That's
see
right.
cuts to education? Are we going to see cuts
Right,
to
right,
transportation? You
right.
name it. I think the state's worried about where do we now find the funds
Yeah.
to cover the Medicaid program.
Or increase your tax basis, which of course always causes concern.
Yep.
So it's might be a great spot for your rural hospital, but maybe not such a great spot for everything else. Well, let's dive into one more item before we
Mhm.
close today. It's hard to believe time is already upon us. But you've been a leader for decades. You know, most importantly, you've led through the most difficult times in our careers. COVID, lack of reimbursement coming in. Finally, there were some uplifts. You know the story. But at the end of the day, I think what we see as a bigger challenge is what we just talked about, which is those cuts to
Mhm.
Medicaid programs. It's the cuts to 340B. It's the cuts to low volume adjustment. LVA survives yet another year, maybe,
Mhm.
but that's a big number for us, right?
Mhm.
Disproportionate share. All those things that we rely on are really right now at the forefront of discussion of elimination. Big Pharma logged over 2 dozen visits to Mar-Lago last year, and that's a challenge.
Mhm.
So, at the end of the day, with all of these factors that are surrounding us, what advice would you give regarding the issues of rural health sustainability and hospital sustainability for a new leader listening to this today that's like, how are we going to make it? First of all, share with us any strategies that you're deploying. So I'm sure you're around your boardroom having those conversations.
Mhm.
What are those? What does that look like? And then what? How would you direct another hospital to survive this?
Well, there's really three things. The first we've talked about, and that's advocacy. We've got to tell our story, or someone's going to tell a story about us that may not be accurate. So I would encourage everyone get to know your legislators, both at the
Yeah,
state and the federal level. Take
yeah,
time to make sure they know who you are. Take time to make sure they know how to access you, and make sure you have access to them. That's vital. You got to do that. The second piece is collaboration. I think we've all got to come to terms with the fact that what we have historically maybe viewed as competition, we need to figure out ways to be collaborative.
that's right.
And as I look at just the regions that we provide care for in Missouri, there are other hospitals that overlap part of those service areas. And, 7 or 8 years ago, we'd have fought over some of those
Yeah,
areas.
yeah.
That doesn't work any longer.
No,
We've got to figure out ways to collaborate. We've got to figure out ways to share resources because if we don't do so, we'll never be able to provide services to our community. And then the other area that I think is so very important, and it goes beyond advocacy, but kind of ties in to some extent, we've got to be able to tell a story. And you mentioned the 340B program, which is vital. If I would suspect for every rural hospital across the country,
oh,
340B plays a
absolutely,
part.
it does.
For us, if it goes away, we don't know how we would
Correct.
make anything work.
Us too.
Um, But talking about the 340B program itself is complex, and I don't understand all the complexities of the
Sure is.
340B program, but I understand what that 340B program allows us to do, and I can put a face to that program because it is the mom who comes in and delivers at our hospital. It is the ambulance service that we provide to our communities without any tax support. It's really all the things we do
Mm-hmm.
because it covers the gap between the reimbursement we get from the governmental payers who
Right.
don't cover our costs or come close to it. But being able to make that personal matters and being able to tell a story around those complex issues resonates with people.
Absolutely agree. Excellent advice. Excellent strategy. There are the most tumultuous of times ahead of us. I believe the phraseology, you ain't seen nothing yet. Even if, individuals are counting on any type of midterm relief, we know, you and I both know, it's going to take 3 to 5 years to turn anything at this point. So we've got to get in our boardrooms. The advice I think you would give, I would give, is get inside your boardroom, create it as a war room, have those discussions about prioritizing the services that you offer, community benefit, look at your growth strategy, develop a plan, and hit your legislative body very, very hard with the reality that you need your local hospital. I would venture to say, Craig, you're probably one, if not the largest employer in your region, correct?
We are 3 times larger than the next largest. So,
That's
absolutely.
unbelievable.
Yep.
So you're absolutely leading the way. It's always great to talk to a leader of your caliber to learn about what you're doing in the corner of your world that could impact others in our industry. It's so insightful. One last thing that I would ask you, and we're doing this on each of our podcasts now, for new listeners who are maybe new to healthcare, there's a lot. I mean, our heads are swimming every day. We get interrupted by all of the things that are happening nationally and at the state level, and then we still have to step back and run a hospital, right? We still have to worry about, the temperature in the OR and the humidity, and we're worried about all these things, but we have to balance it. We have to balance our board, our community, what's happening all around us, and it can be very challenging for young leaders. What advice would you give to a young leader today? Sage advice, aspiring advice about how to deal with today's times.
Two things. One, get involved with an association. Our
Agreed.
organization is very involved with the Missouri Hospital Association. I'm actually the immediate past chair of the
Oh,
association.
good for you.
We find great value in that association membership. We receive a lot of resources. As an independent hospital, you just don't have access to all the things you need, but that
That's right.
association helps to fill the gap and provide a lot of those resources. So whether you have a professional association, a hospital association, get involved with those associations because they can help provide resources. The second is, and JJ, you understand it, I understand it, and the saying is true: it's lonely at the top.
Yeah,
Um, find trusted resources because someone has likely figured out a solution to a problem you have. If you have a
that's
trusted
very true.
resource and you have a network, rely upon that network, rely upon those resources. I have a friend who's the CEO of a hospital in Hannibal, Missouri. Todd Aarons is his name. We talk every single week and we
That's
compare
incredible.
notes and we
Yeah,
bounce ideas off one another. Next week, there are 5 hospitals, all independent rural hospitals, who are meeting in Hutchinson, Kansas. Hospitals from Iowa, Texas, Missouri are getting together to share best practices.
good for
Someone
you.
out there is doing something better than you. Figure out who it is and then replicate it.
That's incredible advice. Craig, thanks for the work you're doing. When you go to Washington, I think it's important to understand you're not just representing Missouri or your Memorial Hospital. You represent me. You represent small hospitals, critical access. We're in mid-size vital. You're in mid-size vital, representing hospitals across the country. So thank you for your advocacy. What you do in D.C. has so much implication on how we run our business as well. I want to thank you for being a champion and an advocate. And based on this interview, you're going to be back for 2 or 3 more podcasts, my friend. So thanks for joining us. It's been great to
Thank
have you.
Yeah, well, thank you, JJ. I've enjoyed it.
And thanks to our listeners for tuning into Rural Health today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday wherever you get your podcasts. And don't forget to check out our latest updates and resources at Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed so you never miss an episode. Until next time, remember, Rural Health Strong.